Well, thanks so much for joining me today for episode 6 of season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. As always, I want to give a big shout out and thank you to the SCAN Health Plan for generously funding and supporting the Healthy Skeptic MD. SCAN Health Plan is the largest independent nonprofit Medicare program in California. It does a great job for a very frail and vulnerable population of patients. So I have been doing the Healthy Skeptic MD podcast for the last year and a half. I've really enjoyed doing it, loved it, so appreciate the audience and those of you who have followed me, and really appreciate all the guests who have generously donated their time to be on the podcast. I've learned so much from you all, and I'm sure the listeners have as well. After a year and a half, I am actually planning to take a little bit of a pause from the podcast, but for a very good reason. As many of you know who have been following me, I recently started a new medical group for patients experiencing homelessness. We just started seeing patients about 6 weeks ago, and we have gotten really busy, and we have a great opportunity to grow our program. Very excited about it, but I want to make sure I'm devoting enough of my time to growing this new group and striking while the iron is hot. So I'm going to take a pause on the podcast and very much hope to be back again in a couple months. If you do search and subscribe to the Healthy Skeptic MD, you'll be able to catch up when the next episodes start coming out, whenever that may be. But the good news is we have one great final episode. We will end with a bang before this pause. And my guest today is someone who I've really been honored to get to know and meet through this work I'm doing with patients experiencing homelessness. It's Miss Jean Galiana. She is the coordinator for older adults within the LA Housing Services Authority. Really unique role, and she brings a passion to both older adults and homeless care and services. And Jean is also a very interesting person. She recently authored a book that she's going to tell us about today. So without any further ado, let's jump into my discussion today with Miss Jean Galiana. Well, thank you so much for joining me today, Miss Jean Galiana.
Well, thank you for having me, Michael. Looking forward to talking to you.
So you have a really interesting background. You have a master's degree in gerontology from the University of Southern California, where I used to work as well. And how did you get interested in the field of gerontology in the first place?
Well, it wasn't something that I thought I was going to be interested in, but when I was in the process of making a career change several years ago, someone introduced me to a nonprofit in New York City that focused around health. And I was really interested in working with them. And so they were looking for someone who could show them more about elder care. That was their subject thought. Their focus of the nonprofit, which is global, is healthcare. They wanted to know more about elder care. So I was asked to scope for best practices in what we referred to at that time as elder care. But as I got into the process of looking around for who's doing things right or creatively, or I learned that aging and elder care is a lot more than comorbidities and doctors and pills and medicine and illness. No offense to you, Dr. Mike, of course. But
I couldn't agree with you more on that.
Oh, great. Yeah, it was eye-opening to me to learn how important the other aspects are, the psychological aspects, the social aspects, of course, along with the biological aspects of a person's life. And also learned about really the importance of the social determinants of health, like clean air, clean water, access to transportation, green spaces, parks that are accessible to people of all ages and abilities. And of course, there are many other social determinants, but of course, now my main focus is housing, and housing is health and is a big social determinant of health. So I got into scoping for best practices. So I reached out and talked to people who were doing things that I thought were really interesting, both aging individuals and people who were leading programs that I thought were transformative or at least innovative. And from there, I got to talk to a lot of interesting people. And then the bug just bit me virtually to my passion for all things older adults.
Well, it sounds like you're in the field for all the right reasons. I had a previous guest, Dr. Laura Mosqueda, who's a geriatrician, and she said the reason she went into geriatrics is simply she liked hanging out with her grandparents. She thought they were cool people, and so it's just always interesting to hear how people get into the field. I've always said that older patients are some of my favorites to take care of. They're the most appreciative in a lot of ways. They have the best perspective on things. So I do think it's a fun population to work with if that's your interest.
Yeah, and I have seen that people, a lot of the people in this field are brought to the field of aging because of a personal experience. And my mom lived with a pretty fast progressing form of dementia that unfortunately killed her at 73. And we were, my brother, who's a physician, and my other brother, who's a hospital president, we were all just completely overwhelmed with how we were going to serve her best and honor her best throughout her challenge. So most certainly when they mentioned aging, my first thought was, no, I can't take it any more of that. But then as I started hearing about people really making a difference, I said, I have to jump on that train. So yes, I have the personal history myself.
Well, you've gotten so much into the field, you even wrote a book about it recently. And the other thing I'll say, it's available on Amazon for purchase as paperback, but it's also available download for free, which is a great option. It's called Aging Well, Solutions to the Most Pressing Global Challenges of Aging, just published about a year and a half or 2 years ago. How'd you get interested? And can you give us a brief synopsis?
Well, yeah. It was kind of overwhelming to be tasked to write a book because I hadn't written one before and I pretty much did it on my own. But I was contracted by the same nonprofit to compile distillations of the learnings from the interviews that I'd conducted and put them together in a book that made sense. And because these interviews really displayed incredible solutions to challenges, that was the focus that I took. And so the book discusses challenges in aging around the world for health systems and individuals. And the interviews provide solutions for those challenges. So yeah, it's an exciting process. There are challenges that were not covered in the book, but the ones that are really do have some innovative solutions that are encouraging. And yeah, like you said, it's available free on the Springer website. Springer is the publisher. And to date, it's been downloaded like 69,000 times. So I can't compete with, James Patterson, but for a book on aging, I'm really happy that people are reading it.
Yeah, well, congratulations. I've really enjoyed it. I'm about halfway through it. One of the things that you talked about that really caught my attention so far is long-term care insurance is such an important thing that many of us, I have to admit, I don't myself have long-term care insurance. Can you tell us what is long-term care insurance, what percentage of Americans have it, and why is it so important?
Well, it's really important because we're all aging, the baby boomer generation in particular, and due to modern medicine, we're living longer with multiple chronic conditions and comorbidities, which is really exciting. But also, we will need long-term care, which is care that takes care of us when we're not able to take care of ourselves independently. And not 100% positive of the percentages of people who have long-term care insurance, but it's a really big deal. It's a big expense. And Robert Wood Johnson had a publication, I think back in 2014, that talked about the cost of long-term care insurance. And they projected that the cost of long-term care insurance in the United States could be determined by the cost of long-term care insurance in other developed countries like United Kingdom, Japan, and Germany. And that cost is 2.5 to 3% of the gross domestic product. So there's a lot of spending in long-term care. And the other aspect of why it would be great if everyone had long-term care insurance, but we could talk about the barriers and why many people will not and do not have it. But the total spending in 2011, this is old data, was $45.5 billion. And the important part of that wasn't just government spending. 21.5% of that was paid directly by patients or their families, and most often by patients' spouses and their daughters. So this is an important fact where people's monies that are in their homes or in their savings account are being drained to care for their loved ones. That money will not go on to their next generation to help them go to college, obtain their own housing. And really, this, sadly enough, like so many things, disproportionately affects people of lower income. People really need long-term care insurance, but there are a lot of barriers to long-term care insurance. Mostly, it's expensive. It's really expensive. Again, lower income folks can't afford it. For instance, my policy next year, I've just been notified by Genworth, will go up by 69%.
Well, that's actually, I'm embarrassed to say, the reason that I don't have it. I'm, in the medical field, so I was aware it's an important thing. I looked into the rates, and it just is so expensive. I'm sure I could afford it, but it's just would be such a big expense. It was just hard to stomach and pay the bill.
That's the issue. So there are two. There, if we look at people in three tranches, first of all, there are people who will be able to afford their own long-term care insurance. I have friends who are in that category, and good for them. You're probably in that category. Then there are people in the middle who will not go on Medicaid, likely will be financially stable enough that I will not go on Medicaid. So I won't have Medicaid to pay for my long-term care insurance, but I also don't have millions of dollars in the bank either. So I'm sandwiched and really, along with many other people, need it. My policy compounds annually, which takes up about 40% of the premium cost. So eventually, once I get older, I may ask for them to revise the policy so that it doesn't compound, and I can have a better premium.
Well, that's another barrier. It's so complicated.
It's so complicated. So complicated, you can't even believe it, because now there are a whole bunch of new policies that are combined with life insurance, and each one of those policies has so much nuance that it's really incredible. I spend a lot of my time talking to people about theirs, and I have a consultant who advises me because even I can't figure it out. So it's true. But when we talk about long-term care insurance, if you're in my category, you're probably not going to be able to afford extended long-term care in your lifetime, but you're not going to be a Medicaid recipient, as far as you know. The best advice I get from my contacts is buy young. And buy young in this situation means between 50 and 55. Don't wait.
That's great advice. Probably something that's relevant to all of us. The other thing, Jean, that I really appreciated about your book, you talked about the importance of bringing health services, medical services to where patients are, in their homes. That when people get older, the medical infrastructure isn't well suited for them, and that's particularly true in the fields that you and I now work with homeless populations, bringing care to them. But could you talk a little bit about that?
Yeah, and the book was written in 2019, long before the pandemic, where older adults were in danger in congregate settings. But still in all, back then, emergency rooms are not good for older adults. The longer they're there, if they experience a higher level of cognitive decline. If they're already in cognitive decline, some of them don't regain it. Hospitalizations. Hospitals are not safe places for older adults. Not just to mention pandemics and flus. There are infections, C. diff, and one profound, and there's hospital-induced delirium, which can be very challenging. But there, along with nursing homes, hospitals limit people's ability to walk around, and it's correlated with loss in function. And function is everything. So the longer you sit in a bed and aren't able to get up and make your coffee, or use your own restroom, or walk around and water your plants, walk out to the backyard, all of that is limited in skilled nursing and hospitals. And it's not limited when you're receiving your care and support in your home. So it's all of the people who I interviewed who were providing these kind of services had incredible outcomes for their patients. So we have Dr. Bruce Leff from Johns Hopkins. He created a hospital at home program. So, you get to the emergency room, if you qualify, we're going to give you hospital care in your home. We've got people providing emergency medicine. You don't even have to go to the emergency room. Just make a call, and Dispatch Health is one that's growing rapidly throughout our country, and it's such an extraordinary example. They'll come to your house. So if you work long hours and your child is sick, you don't need to schlep them into the emergency room. They'll come to your home and take care of you there using the highest level of remote technology that just keeps evolving. So that's really wonderful. I know Northwell Health has an emergency services at home.
And I, at the risk of sounding like an infomercial, we have a sister company within the SCAN group called Welcome Health that's about to launch and provide in-home geriatric services. That'll be another option soon in the Southern California area.
I can't wait to learn more about that. It's just thrilling. And, there are programs like at Northwell Health with Dr. Smith where they provide palliative care in the home. And palliative care extending through the continuum of hospice. And most people want to stay in their home. It's person-centered, it's person-directed, and it's just the right care at the right place. So those programs of being able to bring everything at home is really exciting.
Yeah, well, I agree with you 150%. It's 2022 and we also have technologies and, not all this stuff can be done remotely, but we also don't need to overwhelm ourselves that you need to send someone into the home every day of the week. Maybe it's a monthly visit in person, but the rest of those interactions can be remote or telephonic even. So there are pragmatic ways to bring care into people's homes. So Jean, you have fallen into a very interesting subgroup within the field of gerontology, which is homeless older adults. That's how we actually began working together, because I mentioned in this podcast before, I'm leading a new street medicine medical group for patients experiencing homelessness. And I guess the first question that I often get asked is, most older people aren't homeless, right? Isn't that a younger person's problem? Is that misguided?
Well, that's definitely not misguided. It's the fastest growing cohort of homeless individuals. And it's of huge concern. And one thing to be of notice for older adults, which is really, it's an important statistic, but it's heartbreaking, is that nearly 50% of our homeless clients who are 50 and older fell into homelessness at the age of 50 and older. So they didn't age into homelessness. They didn't become homeless when they were 30 and now they're 50. So it's about half of our homeless population.
I actually just had the oldest patient I've ever cared for, who's almost 91 years old. You typically don't have people that old because people often don't survive that long. But more and more we're seeing out in the streets people who are older, and even folks in their 40s or 50s who have been on the streets for a few years can biologically seem like someone who's a lot older than they are.
Yeah, not just seem, but present geriatric symptoms and of people who are anywhere from 20 to 30 years older. So technically, yeah, the street ages people.
So tell us about your role. Before that, do you even mind giving a little overview of what the Housing Service Authority is in Los Angeles?
Absolutely. The Los Angeles Homeless Services system, we were called it LAHSA for short. It began back in December of 1993 when the Los Angeles County Board of Supervisors and the mayor and the city council got together and they created this joint powers authority, which LAHSA is. We're held jointly between the city and the county. And LAHSA, it's the lead agency in Los Angeles in their continuum of care, which is their regional planning body that coordinates housing and services for families and individuals who are at risk of or currently experiencing homelessness in the county. LAHSA provides not just funding, but program design, outcomes assessment, technological assistance to more than 100 nonprofit agencies. So all of our agencies provide a continuum of programs that range from outreach to access centers to prevention to emergency housing and permanent supportive housing. So yeah, it's a big entity.
Yeah, to put it succinctly, it is the place to go if you have a patient who's homeless and wants to get plugged into the system to be considered for subsidized or housing through one of the programs. And why does LAHSA need a division for those who are aging?
Yeah, well, as per the last Los Angeles homeless count, which was 2019, I'm glad we're in the process of doing one this year, volunteering tonight. Um, the older adult homelessness increased by 20% from 2017 to 2020. And all research indicates that it will continue to increase. And because everyone's realizing this population is growing so quickly, a few years ago at the Older Adult Homeless Coalition, at the Homeless Initiative in the county, that is attended by stakeholders and city and county agencies, they all got together to find out what can we do to address this growing population of older adult homelessness. Older adults have unique needs, and both for prevention and for housing. And so they came up with a plan, and part of their plan, one of the components was that LAHSA should hire a gerontologist. And so that's how I got hired. I'm happy to have that job. I work with incredible colleagues and wonderful collaborate across multiple agencies in this mission driven position.
So, Jean, could I just ask you, what do you think that our system does well for addressing and preventing homelessness in older adults? And then the second question is, where do you see opportunities for improvement?
So there are interesting programs that provide monthly subsidies, which have been very successful. We have a state program called Home Safe that is going gangbusters, really, really exciting, growing and in capacity and scale, and really helping keep a lot of older adults housed. It was mostly prevention, but now we're adding in Los Angeles the ability to serve clients who are currently homeless, which is also great, older adult clients who are APS connected. We also have a Salvation Army program that's street to subsidy and shallow subsidy that has been really interesting. There are other positive programs that are more on a more macro level called, guaranteed income. And those kind of programs, I know they've had one in Oakland, they're starting one in Atlanta. We have one, a small pilot in Santa Monica. I think those programs could be just absolutely incredible.
And just can I ask, I sort of think of Social Security as like a guaranteed income system for older adults. Is this going above and beyond Social Security benefits, or is it for folks who are not eligible for Social Security?
Oh, it goes above and beyond Social Security. The challenge with Social Security is, the cost of living raises or increases annually are based on the consumer price index of workers. So the spending habits of working people. It's not based on the consumer price index of older adults who spend approximately 50% more on healthcare. So as everybody's raises, in comparison, older adults sink, leading them toward poverty over time. So yeah, SSI is good, but we certainly need a consumer price index that reflects their spending and their needs, and we're not getting it.
Well, I mean, I love the concept of a guaranteed income. And I think for older adults who are losing the purchasing power of the money, the income they do get on fixed incomes, it's a great solution that's probably in the long run a lot cheaper for society than letting them run into deficits and the complications from that.
Truly. And even beyond Social Security, rents are increasing. Out-of-pocket healthcare spending is increasing. So while their Social Security is diminishing in comparison to others and in comparison to their real spending, all these other spending items are increasing. So it's kind of a perfect storm.
And how much of your time is dedicated to prevention of homelessness versus addressing those who are already homeless?
I'd say 50%. I'm very dedicated to prevention. And when we hear that someone is at risk, we, meaning myself and everyone I reach out to, like my hair's on fire, trying to find resources and supports for the clients who are at risk. We have programs that serve clients who are at risk. Some of them, not we LAHSA, but in general, some of those programs are burdensome to get eligibility. Like you actually have to have a 30-day quit, instead of just a note from your landlord. And by the time that is all happening and the legal system is involved, we have very little time and our opportunities become more and more limited. If the landlord just said, hey, listen, you're behind on your rent, I'm going to have to, evict you. And we got the call, okay, we got some time. Tell them there are people working on it, and then try to reach out to our wonderful problem-solving program for potential one-time subsidy, or legal services, connect the client maybe to other benefits that they're not using. So we have a lot bigger opportunity, but generally we're running around with our hair on fire, and the people are in a state of utter fear, as they should be. We've had older adult clients who won't pay for their health. It won't pay for their health care or their medications because they can't pay for that, and they keep the roof over their head. They have their utilities shut off, but they still have a roof over their head. So we're putting people in a situation of having to make really difficult choices.
So I've certainly experienced, working with homeless clients and safety net populations, the benefits of a lot of the programs out there. I think LASA and many other groups are doing a lot of good things, and there would be a lot more people on the streets if there weren't these programs out there. But of course, our system isn't perfect. And where do you see the opportunities for improvement?
Well, there are some wonderful programs that have caps on them. And the caps mean there aren't enough slots and they don't meet the need. That's one thing. And that's very challenging. And I did mention some of the rigorous eligibility requirements that doesn't really, and lack of time to bring our interventions.
Well, I think you highlighted some of the points that I would make, and there's good reasons for all these things, but there are a lot of rules and stipulations that make it harder than it probably ideally should be to access services. For example, you need to have an eviction notice to be able to access certain programs, and there's caps, and just once you run out, that's it. And again, all these rules were put in with good intentions in the first place, but when you put it all together, it becomes very bureaucratic.
Yeah, and when we talk about prevention, even though it's obvious, we have to mention the elephant in the room. There's not enough affordable housing. We desperately need more affordable housing, and we need it soon. I think I read one data point that there are something like 21 affordable housing units available for every 100 people who need it here in California. So it definitely, lack of affordable housing is a huge driver to homelessness.
Apologies if I'm putting you on the spot here. I recently had a conversation on this podcast with John Messeri, who's the CEO of the People Concern, and we talked about the average cost of building a new housing unit, close to $600,000, very expensive, and various reasons for that. But there's also private alternatives. We're trying to sort of harness, the public systems are trying to harness private sector to build some subsidized housing. Do you have any thoughts on those two approaches, public versus private approaches?
I definitely think everybody needs to come to the table because the situation is dire, especially here in Los Angeles. We need to see what we can do about the affordable housing that's expiring. And, they say, oh, you only have to be affordable for a certain number of years. We've got about 4,800 of those that are due to convert by 2029. That's a lot of housing. Those aren't units. Those are residences with multiple units. But yeah, I do think private can be really innovative. Can they come together with prefabricated units that are less expensive and bring them and snap them together on site? I think we have to go vertical. But as you know, the tiny home village in Austin, Texas, Community First Village, is an extraordinary example of how tiny homes, and I do mean darling homes with darling surroundings and gardens.
And here in Los Angeles, the VA has done some tiny home projects.
Yeah, they have those little ones, but Community First Village really has houses. They sent an RFP out to real architects to design tiny homes, and they're lovely. They're all different. Each one has its own characteristic, and it's a real village that inspires community, and they live there permanently. So could we do that vertically? Obviously, we don't have the wide open spaces, or could we take over some former, Army bases or The school district has a lot of space. Could we do something like that? I don't know. I mean, if I were going to wave my magic wand and think of what we could do, we've proven that people can work at home, and all these giant towering office buildings should be converted into housing. They're already up and built. But no one's asking me on that level.
That's a great, I had not thought about that, but there certainly are so many corporate offices and headquarters that are not being fully utilized and could be used for many different purposes. Well, this is actually a good segue into the last question I had, because I think I'm getting part of the answer here. With homelessness rising in front of our eyes, a lot of us are getting discouraged. Why should we be optimistic?
Well, we should be optimistic because a lot of us are getting discouraged. It's a topic on everybody's dinner tables, certainly here in Los Angeles and other cities that have high rates of homelessness, I'm sure. It's getting the attention of local, state, and federal government. Thank goodness. HUD stepped in with sweeping funding for our clients who were most at risk of severe illness or death from COVID. That's how we were able to pop up all of these shelters, the Project Room Key shelters, and now the Project Home Key shelters. So there is interest in understanding the need for importance of it. Measure H passed in Los Angeles, which is where the residents voted to pay more taxes to help the homeless situation. So at least it's out there, and it's known to be a problem. And I think hopefully at least Los Angeles and New York and some of the larger cities are at the tipping point where we're going to see more and more spending as it has been promised.
Well, I think that's a great note to end on, Jean. So appreciate your perspective, and it's a really interesting niche you're filling, addressing homelessness in one of the biggest metropolitan areas in the country. So thanks, Ms. Jean Galiana from LAHSA, LA Housing Services Authority, Homeless Services Authority, for joining us today. If you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. We'll pick it up again soon. Thanks, Jean.